Discussion is going to be on the immune system, Chapter 4. Today's objectives are to identify innate and acquired or adaptive immune responses, identify the components of the innate immune system, including mechanical and chemical barriers, the complement system, and phagocytes, understand the process of adaptive immune responses, including cell mediation and humoral immunity, understand the relevance of therapeutic exercise as treatment for immunopathologies, and investigate hypersensitivity disorders, including autoimmune disorders. Our questions for today are: a patient presents to physical therapy with complaints of joint pain, fatigue, and a butterfly-shaped rash across the cheeks and nose. The patient also reports intermittent low-grade fevers and swelling in multiple joints. Based on these symptoms, which autoimmune disorder is the patient most likely experiencing? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Multiple sclerosis. Or D. Ankylosing spondylitis. The second question is: a patient with a history of HIV is referred to physical therapy for generalized weakness and deconditioning. The PTA should be most concerned about which of the following during treatment? A. Increased risk of opportunistic infections. B. Sudden joint subluxations. C. Exacerbation of spasticity. Or D. Rapid onset of osteoporosis. Innate immunity is the first line of defense against pathogens. It is nonspecific and does not differentiate between types of invaders like bacteria, viruses, or fungi. It is non-adaptive and has no memory and has the same response each time. Our first line of defenses include our skin and mucosal barriers. And second line of defense is nonspecific inflammatory response to injury or death. The same immune response happens every time the pathogen is encountered. Acquired immunity is specific and has memory. It recognizes and destroys foreign substances such as bacteria, viruses, fungi, and parasites, and abnormal cells such as cancer. It develops after a pathogen enters the body and a specific immune response is generated. It does have memory, and the body responds faster and stronger if the pathogen is encountered again. It does include two components: humoral immunity and cell-mediated immunity, which will be discussed later. Active immunity is protection gained by exposure to an antigen through natural or artificial means. Natural active immunity results from environmental exposure to a pathogen. Artificial active immunity is gained through vaccinations. Vaccination generates memory cells without causing disease, providing long-term protection. Future encounters with the pathogen result in a strong, rapid immune response. They are currently being explored for diseases like malaria, cancer, HIV, and more. Passive immunity is immunity required without activation of the host's immune system, so no memory cells are formed. Natural passive immunity is the transfer of antibodies from the mother to the fetus via the placenta or through breast milk. Artificial passive immunity is administration of immune serum. It provides immediate but temporary protection lasting from weeks to months until antibodies degrade. Our external defenses include our skin, our body openings, and internal biochemical defenses. The skin is the first line of defense, covering the entire body except for openings. Burns highlight its importance as skin damage increases infection risk. Body openings provide unique protection. Tears contain lysosome to kill bacteria. The ear canal has waxy secretions to prevent bacterial entry. The nose hair traps particles and pathogens. Stomach acid protects against ingested organisms. And the urine has pH to help prevent infection, just to name a few. Our internal biochemical defenses include mediators, phagocytes, and natural killer cells. These work to defend against pathogens that penetrate the epithelial surface, such as in the respiratory system, GI, or genitourinary tracts. Phagocytes engulf foreign particles, while natural killer cells attack virus-infected tumor cells. Phagocytes play a role in immunity. They are part of nonspecific innate immunity. Phagocytes ingest and kill microorganisms like bacteria and fungi to protect the body. The principal phagocytes include neutrophils, which are the most abundant blood cells, which increase in number during infection. They directly kill organisms and produce pus after dying post-phagocytosis. And monocytes circulate in the blood and mature into macrophages in tissues. Macrophages are large eaters, clearing pathogen debris and aiding specific immune responses by presenting antigens to lymphocytes. Other leukocytes include eosinophils, which combat parasitic infections and allergic responses, release granules to kill large organisms, and basophils and mast cells. These are involved in allergic reactions and inflammation by releasing histamine, which dilates blood vessels and increases circulation to the infection site, bringing more phagocytes. The phagocytosis process includes pathogens being engulfed and digested by enzymes within the phagocytes. After neutrophils act, macrophages clear debris and kill the remaining pathogens. They also present antigens to lymphocytes to trigger specific immune responses. Cytokines are released by macrophages to trigger immune responses, raise body temperature, and stimulate T cells, which are key to specific immunity. Neutrophils, macrophages, and eosinophils work together to fight infections. Neutrophils kill small pathogens, macrophages handle larger ones and clean up, while eosinophils target larger organisms. T lymphocytes are broken into a number of different categories. There are helper T cells, or CD4. These are activated by macrophages to stimulate immune responses. There's cytotoxic T cells, or CD8, which target infected or cancerous cells, and natural killer cells, which kill certain viruses, infected, and tumor cells. Inflammatory mediators include the complement system, cytokines, and natural killer cells. The complement system is composed of 20 proteins involved in the acute inflammatory response. It functions to enhance immune function by coating microorganisms to make them easier for phagocytes to ingest. Participating in bacterial lysis, or destruction of bacteria, forming protective barriers around microorganisms to prevent further infection. Cytokines, including interferons, act as messengers within the immune system and between the immune system and other body systems. Interferons are produced when cells are infected by viruses. They coat neighboring uninfected cells, making them resistant to viral infections. They help regulate immune responses and form an integrated network of immune signaling. These mediators, along with phagocytes, play key roles in detecting and eliminating pathogens and coordinating the overall immune response. Natural killer cells are large granular lymphocytes. They kill virus-infected cells, other intracellular microbe-infected cells, and tumor cells. To cause infection, pathogens must bypass innate immune responses and surface barriers. There are two types of acquired immune responses: humoral immunity, which involves the production of antibodies and B cells to target and neutralize pathogens, and cell-mediated immunity, which involves T cells that directly attack infected or abnormal cells such as tumor cells. Humoral and cell-mediated immunity work together to enhance the immune response. Failure in one can weaken the other, as both are interdependent. Humoral immunity is mediated by antibodies. It involves antibodies found in the body fluids like saliva, blood, and vaginal secretions. B lymphocytes originate in the bone marrow and circulate through extracellular fluid. They have surface receptors known as antibodies that can recognize specific foreign substances known as antigens. Upon recognizing an antigen, B cells differentiate into plasma cells, which produce and secrete specific antibodies, and memory B cells, which circulate for long-term immunity. The role of plasma cells is to produce antibodies that neutralize pathogens in body fluids. The role of B cells is to circulate in the blood, lymphoid system, and tissues for up to a year or longer. They ensure a faster and stronger immune response during subsequent exposure to the same antigen. Humoral immunity is specifically effective against free-floating pathogens like bacteria and is key in the body's defenses against bacterial infections. Humoral immunity is faster than cell-mediated immunity and is often involved in resisting acute bacterial infections. Passive immunity is where antibodies can be transferred to another person via inoculation, placenta, or breast milk. This provides immediate temporary immunity. Cell-mediated immunity targets organisms that hide inside cells, such as viruses and some bacteria, where antibodies cannot reach them. T lymphocytes originate in the bone marrow and mature in the thymus behind the sternum. They learn to differentiate self from non-self and circulate continuously through blood, lymph, and lymph nodes. When T cells encounter a specific antigen, they become activated and produce sensitized T cells that perform various functions. They help B cells produce antibodies, activate macrophages to destroy large bacteria, and help other T cells recognize and destroy virally infected cells, and also assist natural killer cells in killing infected cells. Regulatory and suppressor T cells suppress immune activation to prevent autoimmune diseases and pathologic self-reactivity. They're responsible for rejection of transplanted tissues, delayed hypersensitivity reactions, and autoimmune diseases, and form the basis for skin tests like the tuberculin and allergy tests. Some of the factors affecting immunity include aging, as the immune system naturally weakens with age, leading to increased vulnerability of infections and diseases. Nutrition, lack of calories, protein, and essential vitamins can impair immune function, specifically T cell activation. Zinc is crucial for both T and B cell function, and deficiency significantly depresses immune responses. And obesity can alter immune function and increase susceptibility to diseases like cancer. Also, environmental factors. Exposure to pollution, chemicals, or trauma can weaken the immune system, making individuals more susceptible to infection. Also, medications, chemotherapy, and steroid treatments suppress blood cell formation, leading to weakened immune responses. Surgery, especially invasive ones, can suppress immune responses for up to a month. A splenectomy, for example, compromises immunity against certain bacteria. Burns reduce external defenses, neutrophil function, complement levels, and cell-mediated immunity, making individuals more vulnerable to infections. Both physical and psychological stress have been shown to negatively affect the immune system, potentially leading to increased susceptibility to infections and other diseases. The relationship between stress, mental health, and immune function is an area of ongoing research. Physical activity, including aerobic, endurance, and resistance exercises, has a complex effect on the immune system and neuroimmune systems. The impact depends on the intensity and duration of exercise. Moderate exercise enhances immune function and can prevent the negative neuroendocrine and immunologic effects of stress. Regular, moderate physical activity is beneficial for overall immune health, supporting both the immune and neuroimmune systems. Intense, prolonged physical activity, such as a marathon, can impair the immune system. It may lead to reduction in lymphocyte levels and suppression of natural killer cell activity, leaving the body vulnerable to infections, especially viruses, during the period of open window where the immune function is temporarily weakened. Long duration, intense exercise can lead to oxidative damage affecting cellular macromolecules, including DNA. Oxidative modifications of DNA are mutagenic and have been linked to diseases like aging and cancer. Exercise leads to a rise in blood levels of neutrophils and stimulates their phagocytic activity. Exercises with an eccentric component cause a greater increase of neutrophil response. After exercise exceeding 30 minutes, a delayed rise in neutrophil count occurs, usually within 2 to 4 hours of rest, likely due to cortisol. After mild exercise, neutrophil count returns to baseline quickly, but after prolonged intense exercise, this can take up to 24 hours or longer. Exercise increases the number and activity of natural killer cells in the blood due to a surge in epinephrine and cytokines. The natural killer cell enhancement occurs across all individuals regardless of sex, age, or fitness level. After intense, prolonged exercise, natural killer cell count and cytolytic activity drop below pre-exercise level, typically 2 to 4 hours after exertion. Although this drop is brief, repeated intense exercise might have cumulative negative effects on natural killer cells. Regular moderate exercise, resistance training, and prolonged endurance exercise can induce pro-inflammatory cytokines. Even short bursts of intense exercise can increase white blood cell count, including lymphocytes and natural killer cells, due to enhanced cardiac output and epinephrine surge. After intense exercise, the number of circulating lymphocytes may decrease, leading to reduced lymphocyte responsiveness and antibody production. Intense exercise can suppress immune function. However, regular exercise provides long-term protection against diseases associated with chronic low-grade systemic inflammation. This protection is thought to stem from the anti-inflammatory effects induced by short-term bouts of exercise. Immunodeficiency refers to the state where the immune response is either absent or significantly weakened, which can result from either primary or secondary causes. Primary immunodeficiency is a type of immunodeficiency that is caused by inherent defects in the immune system, specifically involving T cells, B cells, or lymphoid tissue. These defects can be genetic and often lead to congenital disorders that impair the immune response. Secondary immunodeficiency is a type of immunodeficiency that occurs as a result of external factors or underlying disease that affects the immune system. It is not present at birth, but can develop due to conditions or treatments that compromise the immune system. Primary immunodeficiencies are a group of inherited disorders that impair the immune system ability to function properly. These conditions often result from genetic mutations that affect various components of the immune system, including T cells, B cells, natural killer cells, and phagocytic cells, or complement proteins. Over 95 primary immunodeficiencies have been identified, highlighting the breadth of genetic defects that can affect immune function. These disorders make individuals more susceptible to infections and may also increase the risk of autoimmune diseases and certain cancers. Some primary immunodeficiencies may result in a complete or partial inability to mount an effective immune response, leading to a compromised defense against pathogens. T cell deficiencies affect the adaptive immune response and can impair the ability for the body to fight infections, particularly viral ones. B cell deficiencies affect the production of antibodies, leading to lack of defense against bacterial infections. Natural killer cells play a role in recognizing and destroying infected or cancerous cells. A deficiency in these cells can increase susceptibility to viral infections and cancer. Phagocytic cell deficiencies affect the cells responsible for engulfing and digesting foreign invaders. The complement system is part of the innate immune system and helps to destroy pathogens. Deficiencies here can make individuals vulnerable to infections, particularly bacterial infections. Secondary immunodeficiency occurs when the immune system is compromised due to an external factor rather than a genetic defect. These disorders are often the result of another disease or medical intervention that impairs the immune system's function. The causes of secondary immunodeficiency are broad and can include infections, chronic diseases, medications, and other factors that impact the immune system. Some of the causes of secondary immunodeficiencies include infections, where conditions like viral infections such as HIV or AIDS and other chronic infections can lead to secondary immunodeficiency by damaging immune cells or suppressing the immune system. Poor nutrition can weaken the immune system, particularly deficiencies in essential vitamins and minerals that are crucial for immune cell function. Chronic alcohol consumption can impair immune function by altering the function of immune cells and organs like the liver, which is involved in immune regulation. The aging process itself leads to a decline in immune function, making older adults more susceptible to infections and diseases. Autoimmune diseases such as lupus or rheumatoid arthritis, where the immune system mistakenly attacks the body's own tissues, can also contribute to immunodeficiency. Chronic diseases, conditions like diabetes, cancer, and other long-term illnesses can impair the immune system. Some cancers, especially those that affect bone marrow or lymphatic system, can disrupt the immune system's function. Long-term use of corticosteroids for conditions such as autoimmune diseases can suppress immune function. Chemotherapy drugs that target rapidly dividing cells can also affect immune cells, making patients more vulnerable to infections. Radiation therapy is used to treat cancer or other conditions and can harm immune cells that lead to immunosuppression. Iatrogenic immunodeficiency refers to immune suppression that is caused intentionally or unintentionally by medical treatment. This form of immunodeficiency is a result of interventions such as medications, radiation therapy, or surgical procedures that alter immune function. Immunosuppressive drugs are used to prevent organ rejection after transplants or treat autoimmune diseases. Examples include cytotoxic drugs and corticosteroids. Radiation therapy is used in the treatment of various cancers. Radiation can cause lymphopenia and other forms of immune suppression by destroying lymphocytes. The removal of the spleen, which plays a critical role in immune defenses, especially against bacterial infections, increases susceptibility to infections. Individuals with immunodeficiency disorders, whether primary or secondary, are highly vulnerable to infections due to their impaired immune system. These individuals face significant risk because their bodies are unable to adequately recognize and defend against harmful organisms, leaving them susceptible to infections that a healthy immune system would normally prevent. The consequences of immunodeficiency include increased risk of infection, disruption of normal body defenses, opportunistic infections, increased risk with poor health status, and vulnerability to common infections. Human immunodeficiency virus, also known as HIV, is an infection that targets the immune system. If untreated, it leads to progressive immune suppression, developing into AIDS. HIV was first identified in 1981, with the earliest infected blood samples dating back to 1959. Viral emergence is estimated to be around the 1930s based on computer analysis. It involves progressive destruction of T cells, which are cell-mediated immunity, and changes in humoral immunity. It induces autoimmunity in some cases and leads to profound immune deficiency, making the body vulnerable to opportunistic infections and cancers. HIV encompasses the entire spectrum of illness from initial diagnosis to full expression of AIDS. There are 3 stages of the continuum. The asymptomatic HIV seropositive. This is the initial stage where the person is infected but shows no symptoms. Early symptomatic HIV is the stage where symptoms begin to appear, and HIV advanced disease is also known as AIDS, where full-blown expression of AIDS. Not everyone exposed to HIV becomes infected. Not everyone who is infected develops AIDS. The progression from HIV to AIDS is controlled by both host genetic factors and viral factors. The first AIDS cases in the US were reported in 1981. The number of AIDS cases and deaths increased rapidly during the 1980s, followed by declines in the 1990s. New infections in the US have declined to about 40,000 per year, from a peak of 150,000 per year in the mid-1980s. The number of people living with AIDS in the US has reached over 1 million. Deaths from AIDS declined by 63% from approximately 52,000 to 19,000 in the late 1990s. High-risk groups include injection drug users, sex workers, and men who have sex with men. There's an 8% increase in HIV cases among men who have sex with men. Racial and ethnic minorities are disproportionately affected. There's an increase in cases of heterosexual transmission among minority women and women over 50 years of age. Most AIDS cases in the US are among individuals aged 20 to 49 years. Teens account for a growing percentage of new HIV cases, and AIDS in the older population makes up 11% of all AIDS cases in the US. The primary cause of AIDS is HIV, specifically HIV-1, which is a retrovirus. HIV is transmitted through the exchange of body fluids, particularly blood and semen. Transmission is not associated with casual contact. Unprotected anal or oral sex is considered high-risk behavior. Also, having 6 or more sexual partners in the past year, engaging in sexual activity with someone known to be HIV positive, exchanging sex for money or drugs, and injecting drugs. Ethnicity itself is not a direct cause of increased AIDS risk. However, ethnic minorities are more likely to face factors that increase HIV risk, such as poverty, illegal drug use, limited access to healthcare, and living in areas with high AIDS prevalence. Adolescents, especially minority inner-city youth, are at high risk of HIV infection. HIV infection begins with exposure to the virus, which primarily targets and infects T4 helper lymphocytes and which are crucial in regulating immune response. In the early stage or asymptomatic phase, the virus replicates in the body, primarily CD4 cells. Macrophages and B cells are also infected. Cell death occurs due to viral replication, but the individual remains asymptomatic. Seroconversion, which is becoming HIV positive, typically occurs within 3 to 6 weeks, but may take longer. After seroconversion, virus levels in the blood decrease, leaving HIV antibodies detectable in serum. The virus migrates from blood to tissues, infecting CD4 cells and lymphoid tissue. Continued CD4 cell destruction results in the virus spreading into the bloodstream again, targeting remaining CD4 cells. In the middle stage or symptomatic phase, the decline in CD4 cells leads to progressive loss of immune function. Clinical symptoms become evident and the immune system can no longer fight infections or mount specific immune responses. The individual becomes more vulnerable to opportunistic infections and diseases, worsening immune dysfunction. HIV has a high mutation rate, leading to multiple strains within a single individual. These competing viral strains challenge the immune system's ability to respond effectively. The asymptomatic stage is where CD4 count is more than 500 cells. There's lab evidence of seroconversion without symptoms. Some may develop infectious mononucleosis-like illness or subtle viral syndrome. There's a period of clinical latency, possibly lasting years. Individuals remain generally healthy and capable of normal activities. Fatigue and generalized lymphoadenopathy or swollen lymph glands can occur. The early symptomatic stage, where CD4 count is between 200 and 500, is where there's an increased immune system compromise leading to various symptoms such as persistent adenopathy or swollen lymph nodes, fatigue, night sweats, fevers, weight loss, and diarrhea, neurological issues, and opportunistic infections. Fatigue can significantly limit physical activities and work or school attendance. Advanced HIV disease is AIDS, where CD4 count is less than 200. There are neurological manifestations such as HIV encephalopathy, leading to severe dementia, incontinence in the later stages. There's dermatologic conditions such as Kaposi sarcoma, skin issues like dry, flaky skin, nutritional disorders affecting nails and hair, pain syndromes, pain from HIV infection, diagnostic procedures, and unrelated causes. The most common include sensory peripheral neuropathy, abdominal pain, and musculoskeletal pain. Women with HIV experience more pain and greater intensity than men. Neuromusculoskeletal diseases such as peripheral neuropathy, osteomyelitis, osteonecrosis, and HIV wasting syndrome. Also rheumatologic infections, conditions like polymyositis and arthritis. Lipodystrophy syndrome, which is characterized by fat metabolism defects, dyslipidemia, insulin resistance, and fat distribution, fat redistribution, where there's a loss in arms, legs, face, and accumulation in abdomen, breasts, and neck. There's an increased risk of AIDS-related lymphomas, Also, cardiopulmonary diseases. Common opportunistic infections such as bacterial pneumonia, tuberculosis, and cardiovascular diseases are now the major cause of mortality in those on antiretroviral therapy. The primary focus is on prevention in unaffected individuals to reduce the risk of contracting HIV. Emphasis on reducing sexual and drug-using behaviors as key strategies. Early diagnosis is crucial for initiating early treatment and notifying partners. There is no cure for AIDS. However, significant advances in treatment make AIDS a manageable chronic condition. The goals of treatment are to stop HIV replication, increase CD4 cells, and improve immune function. Also, delay disease progression. PTAs must be well informed about the multifaceted aspects of HIV and AIDS by addressing the specific physical, emotional, and social challenges faced by individuals with HIV. PTAs can provide effective, compassionate care. This includes making necessary adaptations to exercise programs, helping manage physical dysfunctions, and being proactive in screening for potential complications. Chronic fatigue syndrome is characterized by unexplained fatigue lasting more than 6 months. It is a combination of factors, not a single disease. It is often triggered by viral infections, immune dysfunction, or neuroendocrine abnormalities and stress. The prevalence is 0.23% to 0.42% in U.S. adult population. There are higher rates in women and minority groups, lower education, and occupational status. The average age of onset is 29 to 35 years, and the illness duration lasts between 3 and 9 years. It can affect individuals of all ages, genders, ethnicities, and socioeconomic status. Risk factors include personality traits, inactivity, acute physical or psychological stress, and previous infections. It is the etiology and pathogenesis. It is multifactorial. There's central nervous system dysfunction, immune system abnormalities, and neuroendocrine disruptions. Personality and lifestyle may influence vulnerability. Triggers include physical stress and psychological stress. There are complex interactions between the central nervous system, immune, and hormonal systems. Common early symptoms include sore throat, fever, muscle pain, and weakness. As it progresses, muscle pain, forgetfulness, and prolonged fatigue increase. It is exacerbated by minimal physical activity and can include lightheadedness, low blood pressure, fatigue when standing or in warm environments. The severity varies. Many experience remission and relapse. Also, post-exertional malaise. Treatment includes lifestyle changes, preventing overexertion, managing stress, dietary restrictions, gentle stretching, and nutritional supplements. Carefully supervised therapy, physical therapy to avoid exacerbating symptoms, and focus on moderate, progressive exercise activity management to prevent deconditioning. There are medications for pain, sleep disturbances, and other symptoms. Cognitive behavioral therapy to manage mental health components. Gradual increase in activity to help manage symptoms and improve function. Key PTA considerations involve emphasizing moderation and exercise to avoid overexertion and worsening symptoms. Monitor for symptom cycles. Provide support in activity management to prevent deconditioning while avoiding pushing patients too hard. and collaboration with healthcare providers is important to manage the multifactorial aspects of chronic fatigue syndrome. Hypersensitivity disorders. Hypersensitivity refers to an exaggerated or inappropriate immune response leading to various disorders. Hypersensitivity is often called an allergic response, but the more precise term is hypersensitivity, which indicates an increased immune response to an allergen. The damage and symptoms come primarily from the immune response itself rather than allergens. It is classified as type 1, type 2, type 3, and type 4. Type 1 has a rapid response within minutes of exposure. Symptoms include redness, swelling, tearing, runny nose. Type 2 involves destruction of target cells, often due to antibody-mediated destruction. Type 3 is the formation of immune complexes that deposit in tissues, leading to inflammation and damage. And type 4 occurs after sensitization to certain drugs or chemicals. Symptoms take several days to manifest. Type 1 hypersensitivity includes allergic disorders such as hay fever, allergic rhinitis, urticaria or hives, extrinsic asthma, and anaphylaxis. Allergens are substances that cause allergic responses. They can be inhaled, injected, or come in contact with the skin or mucous membranes. Common types of allergens include inhaled allergens such as mold spores, animal dander, dust mites, grasses, and weeds. Ingested allergens include nuts, fruits, shellfish, and eggs. Injected can be venom from fire ants, wasps, bees, or hornets. And contacted allergens can be plants, cosmetics, metals, drugs, and dyes. Immunoglobulin E is the antibody responsible for allergic reactions. It resides on mast cells and connective tissue, particularly in the upper respiratory tract, GI tract, and dermis. Upon subsequent exposure to an allergen, immunoglobulin E triggers the release of histamine and other inflammatory mediators. These mediators enhance and prolong the allergic response initiated by histamine. If the response becomes systemic, widespread histamine release can cause vasodilation, bronchospasm, increased mucus secretion, and edema. This condition is known as anaphylaxis, which is a life-threatening emergency. Symptoms of type 1 hypersensitivity or anaphylaxis include wheezing, hypotension, swelling, urticaria or hives, and rhinorrhea, which is a runny nose, often with sneezing. Anaphylaxis is a severe life-threatening allergic reaction that requires immediate medical intervention. Treatment involves injection of epinephrine, which is essential to restore blood pressure, strengthen the heartbeat, and open the airways. Common triggers for anaphylaxis include bee stings, which is the most common, penicillin, foods such as nuts or shellfish, animal dander, latex, type 2 hypersensitivity or cytotoxic reactions to self-antigens occurs when the body's immune system recognizes its own tissue as foreign or non-self. It results in disruption and destruction of cellular membranes of normal tissues. Self-antigen disorders include blood transfusion reactions, hemolytic disease of newborns, autoimmune hemolytic anemia, and myasthenia gravis. Type 3 hypersensitivity or immune complex disease occurs when circulating immune complexes deposit in tissues around small blood vessels, leading to acute inflammation and local tissue injury. Common affected areas include the skin with urticaria, joints, which lead to synovitis, kidneys, which lead to nephritis, pleura, which leads to pleuritis, and pericardium, which leads to pericarditis. Classic example includes systemic lupus erythematosus, which is a type of vasculitis that affects various organ systems. Type 4 hypersensitivity or cell-mediated immunity involves a delayed hypersensitivity response mediated by T cells rather than antibodies. Common reactions include contact dermatitis, latex sensitivity, or TB skin test reaction. Special implications for the PTA involving hypersensitivity disorders. With type 4 hypersensitivity, there can be delayed skin reactions. Common triggers include lanolin in lotions, ultrasound gels, and other products used in massage or soft tissue mobilization. It is important to observe all patients for delayed skin reactions to substances used in therapy. With the first exposure, no immediate reaction may occur, but antigens form, making subsequent exposures trigger hypersensitivity. It is recommended to test a small area of skin for sensitivity before using large amounts of topical agents. Latex sensitivity. Since the 1980s, the use of latex gloves in healthcare increased, along with reported cases of latex sensitivity. PTAs with known latex allergies should avoid latex gloves and products and use low powder-free or non-latex gloves to prevent exposure to latex allergies. Autoimmune diseases occur when the immune system mistakenly attacks self-antigens because it fails to distinguish between self and non-self. This leads to the immune system directing immune responses against normal tissue, causing self-destruction. There are more than 56 autoimmune diseases that have been identified affecting various organs and tissues, including the skin, joints, and vital organs. There is a spectrum of autoimmune disorders. Organ-specific diseases are conditions that cause localized tissue damage due to specific autoantibodies targeting a particular organ. Intermediate disorders are where lesions may be localized in one organ, but antibodies are not organ-specific. Non-organ specific diseases are diseases that involve widespread lesions and antibodies throughout the body, not limited to one organ. Many autoimmune diseases, particularly organ-specific and systemic types, are seen in rehabilitation settings and can impact mobility, daily activities, and overall function. Etiologic and risk factors for autoimmune disorders. Acquired diseases. The causes of autoimmune disorders are often unclear and may involve a combination of genetic, hormonal, and environmental factors. Risk factors include genetics, however, no single gene is responsible, but certain gene clusters increase susceptibility. Hormonal factors. Women are affected more than men. The hormonal influence is complex. Autoimmune diseases are more common in women in their 20s and 30s when estrogen levels are high. Some diseases worsen after menopause or puberty when estrogen levels are low. Pregnancy can impact disease progression. Women with rheumatoid arthritis or multiple sclerosis may experience remission. Women with systemic lupus erythematosus may experience exacerbations. Environmental factors such as chemical exposure, toxins and drugs, and sunlight exposure. Viruses and stress are also implicated. Some women with silicone gel breast implants have developed autoimmune diseases linked to musculoskeletal issues. The pathogenesis of autoimmune disorders include immunoregulatory disruption, where the autoimmune disorders occur when normal immune responses, both cell-mediated and humoral, turn self-destructive, causing tissue damage. Or immune system involvement, where the innate immune system plays a crucial role in T cell activation. More than one part of the immune system may be involved in developing autoimmune diseases. Types of autoimmune diseases. Some affect a single organ, such as type 1 diabetes affecting the pancreas. Others affect multiple systems or organs, like multiple sclerosis. Some conditions overstimulate organ function, such as Graves' disease. Autoantibodies are produced by the body against its own cells or organs. These antibodies are characteristic of autoimmune diseases. Examples include myasthenia gravis, Graves' disease, and insulin-resistant diabetes mellitus. Clinical manifestations of autoimmune disorders. Some of the common clinical features include synovitis, pleuritis, myocarditis, endocarditis, pericarditis, peritonitis, vasculitis, myositis, skin rashes, connective tissue changes, and nephritis. Some other symptoms include fatigue, malaise, myalgias, and arthralgias. Autoimmune diseases can be difficult to diagnose due to poorly understood mechanisms, overlapping symptoms, and vague clinical signs, such as lethargy and migratory joint pain. Diagnostic tests may show thrombocytopenia, leukopenia, immunoglobulin excess or deficiencies, anti-nuclear antibodies, rheumatoid factors, false positive serologic test results, elevated muscle enzymes. The general treatment approach aims to balance suppressing the autoimmune response to prevent tissue damage while maintaining sufficient immune function to defend against foreign invaders. Medications include corticosteroids, which are used to suppress inflammation, and other medications to provide symptomatic relief. Systemic lupus erythematosus. Lupus erythematosus is a chronic autoimmune disorder that can manifest as either discoid lupus erythematosus, which affects only the skin, or systemic lupus erythematosus, which can involve multiple organs or systems of the body. Latent lupus does not meet the full criteria for diagnosis. Symptoms may persist without progressing to classic systemic lupus erythematosus. Drug-induced lupus occurs due to certain medications, and symptoms resolve once the drug is stopped. Late-stage lupus involves chronic diseases, more than 5 years, with complications like kidney disease, atherosclerosis, and congenitive dysfunction. SLE predominantly affects young women, especially during childbearing years. It's 3 times more common in African American women compared to Caucasian women, and is also prevalent among Hispanic, Asian, and Native American women. There is a genetic predisposition, as first-degree relatives of people with lupus have higher incidence of the disease. The cause of SLE remains unknown, but is believed to involve a combination of immunologic, environmental, hormonal, and genetic factors. Autoimmunity is central, with the immune system attacking the body's own cells. There is a higher frequency among first-degree relatives. Stress, infections, sunlight, immunizations, and pregnancy can provoke or worsen the disease. Estrogen particularly plays a role, with exacerbations often linked to estrogen use and contraceptives. Certain medications can trigger lupus or worsen its course. The pathogenesis includes the body producing antibodies that target its own cells. The antigen-antibody complex deposit in tissues leading to inflammation and tissue damage. The wide range of targets makes SLE a disease of generalized autoimmunity. Tissue damage can occur due to inflammation or vascular abnormalities at the organ level. The clinical features of SLE vary widely with involvement of different organ systems. In the musculoskeletal system, there can be arthralgias or arthritis are the most common symptoms. Joint pain typically affects the small joints. Acute or chronic arthritis. Deformities may occur, including ulnar deviation, swan neck deformity, and tendon ruptures. Skin rashes often worsen with sunlight exposure. A butterfly rash over the nose and cheeks is common. Discoid lesions may form on the skin. Alopecia and painless ulcers in the mouth and vagina are common. Vasculitis can cause lesions and Raynaud's phenomenon. Pleuritis, pericarditis, and dyspnea are common. Severe cases involve myocarditis, endocarditis, pulmonary hypertension, and heart failure. Headaches, depression, irritability, and seizures may occur. Cognitive dysfunction, emotional instability, and even psychosis can develop. Cerebrovascular events and peripheral neuropathy may also occur. Kidney involvement is common. GI symptoms such as nausea and vomiting, anemia, and enlargement of the lymph nodes. SLE tends to fluctuate between exacerbations and remissions, with symptoms worsening during flare-ups. Each patient's disease course is unique and symptoms can vary in severity. Physical therapy interventions play an important role in managing the overall treatment plan for individuals with SLE. The PTA's role involves understanding the impact of SLE on various body systems and tailoring interventions to improve function, minimize complications, and promote quality of life. Key considerations include activity and rest balance. Gradual resumption of activities is crucial after exacerbations. The PTA should assist clients in balancing activity with sufficient rest. Patients with SLE often require 8 to 10 hours of sleep per night and rest periods throughout the day. Energy conservation techniques and teaching clients to pace activities and avoid excessive bed rest, which may exacerbate fatigue, muscle atrophy, and osteoporosis. Joint management follows the same protocols such as rheumatoid arthritis. The PTA should focus on joint protection techniques and educating the client on safe movement patterns to avoid exacerbation. Skin lesions should be thoroughly checked at each visit. The PTA can assist with skin care and prevention of breakdown, particularly in areas exposed to friction or pressure. Generalized fatigue is a common and debilitating issue in SLE, which can affect both physical and cognitive functioning. The PTA should instruct clients on ways to manage fatigue through activity pacing, rest periods, and avoiding excessive exertion. Prescriptive exercise should be designed to strengthen muscles, improve endurance, and avoid stress on inflamed joints. Focus on low-impact exercises that improve cardiovascular health and muscular strength without exacerbating inflammation of the joint. Range of motion exercises can be useful to maintain joint mobility. And some complications include osteonecrosis and septic arthritis, osteoporosis, infections, renal and neurological complications, Raynaud's phenomenon, to name a few. Fibromyalgia is a chronic pain syndrome characterized by widespread muscle pain, tender points, fatigue, and other associated symptoms. It is considered a syndrome rather than a disease, and its pathogenesis is multifactorial. Fibromyalgia is recognized as a biologic disorder with neurohormonal dysfunction, particularly involving the autonomic nervous system, immune system, and sleep physiology. Key features of fibromyalgia include chronic muscle pain, sleep disturbances, fatigue and cognitive dysfunction, muscle tension, symptoms exacerbated by stress. Fibromyalgia may co-occur with conditions like hypothyroidism, rheumatoid arthritis, SLE, chronic fatigue syndrome, and depression, although the exact relationship between these conditions and fibromyalgia is still under investigation. Risk factors include stress, trauma, viral infections, and rapid steroid withdrawal. A family history or hereditary predisposition may also increase the likelihood of developing fibromyalgia. Psychological distress is often present, contributing to symptoms like anxiety and depression. The pathogenesis includes the autonomic nervous system, and fibromyalgia shows exaggerated response to stress affecting multiple organ systems, including the heart, muscles, digestive system, and blood vessels. This overactivity can cause muscle tightness, poor circulation, and digestive disturbances. Immune cells release pro-inflammatory cytokines, which can sensitize the central nervous system, amplifying pain via glial cells in the spinal cord. Sleep disturbances are a hallmark of fibromyalgia, and evidence suggests relationship between the immune system, sleep-wake cycles, and chronic pain. The role of the PTA in managing fibromyalgia includes a multidisciplinary approach that targets pain relief, muscle strengthening, fatigue management, and improving functional mobility. This includes gentle, low-impact exercises, pain management strategies, fatigue management, joint protection, postural training, and psychological support. Back to our questions. A patient presents to physical therapy with complaints of joint pain, fatigue, and a butterfly rash across the cheeks and nose. The patient also reports intermittent low-grade fevers and swelling in multiple joints. Based on these symptoms, which autoimmune disorder is the patient most likely experiencing? The answer is B, systemic lupus erythematosus. SLE is a chronic autoimmune disorder that affects multiple organ systems. Common symptoms include joint pain, fatigue, fever, and the characteristic butterfly rash on the face. Physical therapy for patients with SLE often focuses on managing pain, improving joint mobility, and addressing fatigue through energy conservation techniques and gentle exercise programs. Question number 2, a patient with a history of HIV is referred to physical therapy for generalized weakness and deconditioning. The PTA should be most concerned about which of the following during treatment? The answer is A, increased risk of opportunistic infections. HIV comprises the immune system by attacking CD4 and T cells, making patients more susceptible to opportunistic infections. PT interventions should include infection control measures, moderate intensity exercise to improve endurance and strength, and close monitoring for signs of systemic illness. If you enjoyed this video, please make sure to like and subscribe.